we have these two chemotherapy regimens that you mentioned, nab-paclitaxel, FOLFIRINOX. There's a lot of people that feel one way strongly towards one regimen versus another, and certainly the subject of a lot of debate. And maybe to level set us, Tom, can you tell us a little bit about the two trials that approved these regimens? What were the patient populations like, and what did the data really show us?
Be glad to. So the FOLFIRINOX trial, or the PRODIGE-4 trial, differed from the IMPACT trial in patient selection. Patients in the FOLFIRINOX trial really all came from France. They were, for the most part, a better performance status slightly than the folks in the IMPACT trial. They were ECOG 0 and 1, whereas the folks in IMPACT were KPS 70% and above, which really doesn't necessarily translate evenly, but may in fact show that there were a little bit poorer performance status patients getting the gemcitabine and the nab-paclitaxel. But on the other hand, both control arms were gemcitabine and the overall survivals were essentially identical. So it does make one question whether there were really truly meaningful differences in the trials with respect to the patients. That said, clearly the FOLFIRINOX patients had more in the way of toxicity, slightly more in the way of neutropenia, diarrhea, than those in the IMPACT trial randomized to the experimental arm. And they had a much higher overall survival, 11 months versus 8.5 months. So I think based on those data, most people feel that FOLFIRINOX might be a little bit more effective, might have a better response rate, but it's, again, with the proviso that cross-trial comparison is very, very difficult and fraught with landmines.
So certainly outside of a clinical trial, I'm just going to take a poll because I want to see if I've got some controversy here. George?
Controversy? You want controversy?
Great taste, less filling. Which would you like? What do you think, FOLFIRINOX or gem-nab?
It depends on the patient. What does the patient want to do? Does the patient want to wear a pump and have potential toxicities, be hospitalized, need Neupogen, Neulasta, a lot of considerations, or they want to get treated weekly and maybe come in every week and then go home and stay at work and still have able to support their family and get their insurance. I think it depends on what the patient, Philip said it earlier, it really depends on what the patient wants and what best fits them. And then I'm gonna stir the pot a little bit. There are good survival data there's this kind of urban legend that we're supposed to use FOLFIRINOX in the really good performance status patients. But there is data out there in the KPS ECOG 0 patients that survival can be as high as 12.6 months, and that data is out there in the public domain.
With FOLFIRINOX?
No, with gem-Abraxane.
Yeah, so, long-term survival.
So it's somewhat of a myth that you can use gem-Abraxane, especially out in the community. I think there is some fear that if you don't have the support for FOLFIRINOX, if you run into side effects, gem-Abraxane is a very reasonable option in that population, that good performance status population. I think the other end of it is the poor performance status patients, we always think, well, let's just give them gemcitabine, but you can give them gem and Abraxane, and there does appear to be a benefit to that group of patients as well.
Okay, so great political answer. Patient, 60 years old, good performance status. Straight off the bat, you have to pick something off the shelf. What do you pick?
Clinical trial.
Yeah, nice. No clinical trial available. Your research nurse has gone on vacation to another Florida.
It's a conversation with the patient. What does the patient want? I make very few decisions. I really partner with the patient, try to figure out what they want to do. And I think both are reasonable in that population, that age, and that performance status. So I think it's very reasonable. But again, ideally, as Philip said earlier, experimental trial. We've got a lot of work to do. We do have new options. Yeah. We've got a lot of work to do, folks. We're still not hitting it, Mark.
Tom?
So I think for the young 60-year-old that you described, if we do not have a clinical trial for them, I tend to put patients on FOLFIRINOX, but I don't think that there's one answer. I think that some patients respond really well to FOLFIRINOX and others don't, and you kind of have to get lucky, and whatever you choose may not be the right answer, and sometimes you'll go to the next line and you'll find that the patients are doing much better. So it's a bit of a crapshoot. I think I still tend to go to FOLFIRINOX in those patients, but I don't have a definite preference.
Caio?
Very well said by the group, but I think, Johanna, we are moving to a new paradigm now. We're thinking about sequence.
Yeah.
We actually have options in pancreatic cancer, believe it or not. So it's going to be a discussion further along among us. But now we have irinotecan in a new formulation that show a benefit in survival combined to 5-FU in second line in gemcitabine pre-treated patients.
Yeah.
So they threw us off a little bit in how to choose the first line, because if you pick FOLFIRINOX, you do not have randomized phase 3 data with gem-nab in second line. But you now have randomized phase 3 data with 5-FU and the Merrimack nanoparticle irinotecan compound. So I tend to go for sequence because I think I would also diminish the risk for toxicities for the patient. And I'll be based in phase 3 trial in my first line and second line treatment.
I love it. Okay, and we are going to talk about the new compound, the MN398. Philip, last
Well,
vote?
I have to admit that if a patient comes to me who's young, let's say 60 years or younger, and very good performance, has good organ function, I have that tendency to maybe recommend FOLFIRINOX over nab-paclitaxel, although I always discuss with them. But if I want to think back, the concept of a triplet versus a doublet, and again, I very appreciate what you said. I think that's a very important point. If we can sequence more tolerable treatments, easier treatments to patients to take. If you look back into other tumor types, we used triplets in esophagogastric patients. Now we're using a doublet most of the time. The same thing will be in colon cancer. How often do you use FOLFOXIRI as opposed to the doublets? So the precedent is there that we use the more tolerable, easier doublets and try to maintain the patients as long as possible on chemotherapy rather than give them treatment that may be more toxic.